This is a 56-year-old gentleman that presented to a off-site hospital about an hour and a half away from Montreal in an altered mental state and multi-organ failure. He had elevated troponins, obviously. So the diagnosis at the time was a NSTEMI, either type 1 versus type 2. He has classic, at 56, he had classic risk factors such as hypertension, cholesterol, and run through. He was known also for hepatitis B, has a history of amphetamine and cocaine use and alcohol abuse. The patient basically was admitted with multi-organ failure, cardiogenic shock, acute renal and hepatic failure, delirium due to acetaminophen intoxication. Due to a predominantly cardiogenic shock phenotype, a TEE was performed, which then revealed a 20 to 25% LVEF with diffuse hypokinesis. Once the patient was stabilized, the patient was referred to the for diagnostic cath lab at his hospital. So as you can see, this is the RCA. It's a diffusely diseased RCA, mainly in the mid part. Procedural consideration, we initially had debated about the vascular access. Again, this is a distal left main bifurcation with multi-vessel PCI. So radial, subclavian, femoral. The one portion that we got when the patient was here, I don't have the image. We're having some issues transferring images from our packs to the live setup. We basically did a angio CT. The right femoral, common femoral is occluded. The left side, the iliofemoral axis was actually very good. We had a 6 millimeter diameter at the level of the common femoral. We also considered doing right heart cath to guide ourselves in terms of use of MCSDs, mechanical circulatory support devices, and also to complete and complement if we do need the LV support. The Impella-CP was used. I mentioned SADIT as an option, but it's really a single access in a patient with severe PAD. So the interventional plan was to aim for complete revas, adjust the plan according to IC imaging using a MLD max OCT-based protocol, use LV support, especially in a case of unprotected left main PCI in a patient with severely depressed or dysfunctional LV function. And the LV support is also required for us since we're planning on implementing calcium modification. The plan was to start with the RCA and then move on to the left-sided system by addressing the circ. If we believe that the circ has a micro channel that we can run through. If not, the LAD would then be done subsequently, and we would finish all this up with the unprotected left main PCI guided by OCT. The plan is to start with provisional, and then if need be, two-stent strategy. The points of discussion: calcium modification, IVL, atherectomy, bearing in mind that the LAD has some tortuosity in it. Bifurcation in the left main. Obviously, as you have all read, EBC main trial debated whether or not upfront two-stent strategy versus provisional was better.
So we stuck the femoral, the left femoral artery under ultrasound guidance with a micropuncture. Yeah. And you can already see the cardiac output is very depressed just by looking at the blood flow. You can also appreciate that there's severe PVD distally in the profunda. However, at the level of the common femoral artery, the arteries are actually very clean.
This is the least disease of the two
vessels. The right femoral, like Dr. Lee said, is occluded. We also perform a right heart cath. Right heart catheterization demonstrated elevated right-sided pressures. So the RA was a mean of 9. The RV was a mean of 14, 48/3. And the PA, we had moderate pulmonary hypertension, 49 systolic, 26 diastolic, 34 average. The LV was at 101/7 with LVDP of 18. So the transpulmonary gradient here is 16. So we have a mixed pulmonary hypertension both pre and post capillary. We also perform oximetry in this patient to calculate the cardiac output using the FIC formula. And the cardiac index is severely depressed at 1.3 liters per minute per square meter.
1.2.
1.2 actually. So it's even
Worse.
So it's way under the 2 level, the 2 cutoff for cardiac index. We then inserted the Impella plate disc. So we inserted Impella always under fluoroscopic guidance to make sure that there was no perforation or dissection, that it was flowing freely. Next slide, we gave the heparin right after. We crossed the aortic valve. So this is just a standard Impella CP installation. Okay, so here plate disc. So we actually obtain a single access Impella. So you can see using the micropuncture needle, we puncture the Impella sheet around 2 o'clock. And then we advanced 6 and 7 hydrophil 6 and 7 sheet. That's hydrophilic. Next slide. And then we're able to advance 035 wire through this access site. And we decided to tackle the right coronary artery at first. So this is the final result of the RCA. We're pretty happy with it. There's still a lot of disease distally, but the main vessel beds are open. You can also notice that there's collaterals going to the circumflex and the marginal. So we hope we'll be able to revascularize that.
So right now, we're gonna
try to wire the circ, see if it's a CTO or not.
So as you saw, we were using the 7 French guideliner inside of a JL to provide us with much more support. And the OCT helped us guide what we were planning for left main prox LAD PCI. However, it wouldn't advance despite having that 7 French guideliner in place. Right now, for the time being, things are actually pretty stable. As you see right now,
it looks.
How does it feel?
Well, it feels like a CTO. I mean, the wire is not progressing.
Okay. You can see from this live injection, that it's probably a recanalized, heavily calcified and recanalized. It's heavily calcified. Okay, so we again are running out of XTA. We'll try with the XT, and if not, we'll give it one last try, what we can do with what we have, fortunately, and then maybe try either the next 2 before we move on to the LED. So the LED and left main PCI would be the Mongo MG14 with close to 4 grams of hip, and also a Gaia next 2.
So we're still trying to see if we can get a wire across the circumflex, because at this stage, the LED to left main, we're thinking that won't require calcium plaque modification based on the OCT. It will definitely make our lives easier if we don't have to tackle the circ today. But we'll see if this wire goes. Patient is very stable. The PA pressure is also very stable. There's a huge chunk of calcium right in the mid portion.
I think we are through.
So you're connected with the other collateral.
Okay.
So that's very good. Let's maybe start with a small balloon and do the circ first. I would do the circ first, get it out of the way, then deal with the LED, and then deal with the bifurcation.
Now the balloon is going in, and it's through. So many things that we can do up to now at this point is obviously balloon. You see the chunk of calcium. Dilatation. The angioplasty performed here in tight calcified lesion. Then we can upsize obviously the balloon, or we could even do granuloplasty, or this would likely allow us, such a lesion would allow us to bring down a microcatheter and switch out for ROTA. Okay.
Un ballon 1,25. Sinon, ballon 2,015.
So this is good news.
So we're going up now with a 2,015 balloon.
Open.
Oh, it's very open. Nice. Okay.
Oh, beautiful. Nice and plump. So right now, what we're going to get is a ballon 2.5. I'm going to do a trap. When you look at the angiogram that we just displayed, one of the things that we have to consider is what to do with the distal bed. You saw the OM2 and 3 had disease. Peux-tu rejouer ce qu'on vient de faire? You see, so my temptation would be to just finish the occlusion and leave some of the distal bed. And,
For positive remodeling.
exactly,
I think they're
is-
going to remodel. They've been occluded for years. I
so-
thought there's a bit of a
Yep.
knuckle.
There's a well-known literature regarding CTO lesions that subsequently, you leave the bed to remodel, it will remodel itself.
We're removing the filter. Now we have a workhorse wire and we're ready to OCT. Cine.
Vas-y.
Let's see what the OCT shows. Mainly
Yes.
fibrocalcific plaques. Here we can see the balloons.
My interest in the OCT was to make sure that we would have optimal expansion.
For the
Sure,
balloon.
sure. It's a 2.5, but
Yeah.
we'll just open it up.
Looks beautiful.
Beautiful.
Okay, great. There's this is actually
There's
looking
no
really good.
disease.
Just
No,
wonder
no.
if the dye,
We'll see. We'll see. We'll finish.
maybe after the LED,
all of
we
this.
can do both, you know?
Yep. So we're using the roadmap again from Philips, which will allow us to use less.
Minimize the
contrast.
dye, yeah. I would not go more distal,
Yeah.
but I wish
It's
my
gonna-
balloon would go a bit. So here more proximal notes at 3.0, even 3.5 vessel. So I'm feeling
Garde
confident.
celle-là. Okay.
Very
It's
good
well
expansion.
expanded. Okay. This is looking good.
Let's see the 3.0 balloon. Let's see how far it takes it. So it's stuck there too, but I think I would go
yeah, I
here.
would go that far. Yeah.
I would go here. There's a fat portion.
Okay. I think it may have ruptured.
I think a rupture.
Oh, I don't know if. Bougez pas, bougez pas. C'est 16.
The balloon rupture, there's a severe calcium. Just see, make sure there's no perf.
Clearly
Looking
well
pretty
open.
good.
Okay, so we have a dissection. You know, it's important to really modify the calcium. We were confident that it was okay. However, there might be some small spicules and the balloon ruptured. So that tells us that at least in the extra plaque space, we've
This happened in
probably-
the left main bifurcation, so we're already expecting.
so we're probably going to have good expansion. Okay, we'll see.
We don't want to inject anymore because we have a
Yep.
dissection.
We're gonna
So we'll
get our
just use the
stent.
roadmap to coordinate the deployment of the stent in the mid.
The patient is quite stable because we're on LV support. So this is actually pretty good. We're quite happy with that. If you see the recent PA pressures, they've actually even lowered a bit. The mean went from 35, 36 to 31.
Let's see if the stent goes down.
Stent doesn't go. I've already called for 2.0 so that we
I'm
can
getting
do,
no resistance, actually going very well.
Yeah. So
So
the roadmap, I think we're happy with that.
yeah, I would go here. It actually went further than my balloon. Okay.
Not to oversell one single company over another, but this is a resolute integrity. I find that these are highly deliverable because of the cell design.
No, my guideliner is going in.
We're gonna do stent boost.
Send boost, please. It's very good.
No, we can pull back.
Sorry, the contrast
No.
came out.
Anyway, okay, I'll go much more timid.
You want to use this on the bifurcation, this balloon?
Oh, I'm not sure. It
Probably
might
not.
be too long. I don't want to stent the whole left main, so this is
Okay,
better for us to preserve.
let's see. It's possible.
Okay. Is- Oh, so we have abrupt vessel closure right now. So I don't know if it's because of the left main. So again, we're under support. We're having a lot of,
Maybe just because of a lot of
yeah,
stents.
well, I don't know if it's the distal bed or
Or is it a
not.
dissection that's proximal?
Yeah, okay. So we go with a stent.
Yeah, I think I would go with a stent
Yep,
proximal, and
okay.
then we'll.
We're gonna have to recoup this. So we have the guide liner in place.
Okay, so you wanna
Well, I think we have
Cover.
to cover the left main. So we've covered everything?
No, no, no.
So we need a longer stent. Go.
Pressure look up. We're putting the patient on level fed, and we are
So this is
hoping that,
live as it gets.
yeah,
So
real hoping that this is
Well-
going to push away the flap and
Yes.
hopefully restore flow to the LED.
if not, then
Yeah,
we
we-
have to believe that maybe the distal LED is compromised. So if it's not that flap from the
We'll go
from the
balloon to this
perforation,
LED.
but balloon rupture, they might be the distal bed, but I think we sized it accordingly, and when we will see. That's good.
All right, it's not going.
Yes.
It's at the stent. Yeah.
So it's a curved. Push it.
Let me try to get the
Yeah, oh, you got
guideliner.
it. You got it through. Yeah, guideliner is there.
Yeah, guideliner is inside.
There you go. All right.
Perfect.
So it's
Oh,
back,
beautiful.
everyone.
Beautiful.
We'll see the flow where if Timmy 3 is there, I'll go gentle.
We're dilating the
Come on.
left main ostium.
Okay, size 16.
Take it here.
Yep, we're good.
I'm gonna take the wire from the circ. I'm gonna
So
bring
this
in
is
the LED.
the circ
The
wire?
circ is a cyan blue.
Okay.
Take it
Show me.
out.
Yeah,
Just
show me. I just
under
wanna pull
fluoroscopy, make sure
to
it
make sure we
doesn't.
don't crimp this thing. You want to use this wire or a
Yeah.
different wire? Okay, 1040. I think it might be damaged, so it might be.
Yeah,
tough
I
for
think
you to-
so.
I would.
Let's
switch
let's
one.
remove. This is good. So,
This is what you want. You're crossing into the stent, and
oh, I don't even
rubber,
know how.
uh,
I don't even know how it got in there so easily.
so is it the man or the wire? Ballon,
think-
ballon 2-0, s'il vous plaît.
I
We're
believe
gonna
it's
take a
the wire.
2-0. It's a combination of both.
Okay, open. It must be the wire.
14. We'll just
Good
keep it on
expansion.
for 30 seconds so that we recoup that flow. Hopefully we might not need to do much more.
Okay.
Okay, so we'll do less than 30 seconds, but I think. All right, let's do this and see.
Oh, actually,
Okay,
want to do drug-eluting balloon?
yeah.
What do you think?
Yeah.
Maybe do a LAO
Yeah,
cranial?
yeah, that's where I'm already headed.
Small. Huh?
Yeah, I'm not unhappy with this. I would tend to leave this.
Yeah, I think let's leave. Let's do OCT.
Yep. Okay, OCT.
OCT, and then
You
let's.
wanna pull the wire.
Yes. So you don't want to keep it for marker?
Okay, we can keep it. We can
Keep it
keep
for
it.
marker. No, this is not going.
Yeah, lift.
It's the same issue here.
Same
man.
issue again with. Yeah,
Should I remove the wire?
yeah, you might. Okay, just remove the diagonal wire. We'll see. I don't want to damage the OCT. And French went through, and we're going to get the OCT going. We're going to get this OCT going, pulling back a bit of the 7 French. Là. Show us.
Here's our final OCT catheter. We hope it works.
If it's damaged and we switch out to get an IVIS. We have obviously for complex PCI, we always want to be sure that we get to see the left main.
Okay, let's.
Bring down. Okay, that's good. All right, bring down. Go whenever you're ready. We'll see.
Don't inject the whole thing because it's
No,
so
no,
short.
for sure. We'll see if that position at the level of the left main is fine. We'll go see if you can go focus on the. If you can focus now on the OCT, we'll see. J'entends rien. Est-ce que Sophie, elle est là? Est-ce que c'est fini? J'entends rien. Ils ont
Personne
pas,
n'a rien dit.
personne nous répond. No, it's actually very good.
It's very high.
Very
It's
high.
hypertension, my
Actually,
friend.